Good morning. My name is Dr. Jason Wasfy. I am a cardiologist at Mass General Brigham. I'm an associate professor at Harvard Medical School, and I'm an associate editor of JACC. And I am delighted to be here today with Kristoffer Skaarup, a PhD student at the University of Copenhagen, and the first author today in JACC of a really important research letter about RSV vaccine in individuals with heart failure. So thanks for joining us.
Thank you so much for the kind introduction.
I would love to hear you summarize and tell us about your work.
Of course. So in the present study, we conducted a pre-specified analysis of the DAN-RSV trial, which I think I should probably summarize before moving on to this analysis. So the DAN-RSV was a nationwide pragmatic randomized trial, open label and phase 4 of almost 132,000 citizens in Denmark, aged 60 years and older, which were randomized to RSV vaccine, the bivalent RSV perfusion F vaccine or no vaccine. And this was conducted during the winter season of 2024 to 2025. And the primary endpoint was hospitalization for RSV-related respiratory tract disease hospitalization. And the trial was positive for its primary endpoint with a risk reduction of 83%. And from the beginning of this trial, we found it important to explore the vaccine effectiveness in individuals with heart failure. As we know, these individuals are both at elevated risk for severe complications from infection, and they may also exhibit attenuated vaccine responses with lower immunity. And we therefore conducted an exploratory analysis to compare vaccine effectiveness against both respiratory and cardiovascular outcomes by heart failure status. And we also looked into heart failure subgroups. And I might add that we evaluated cardiovascular outcomes as multiple studies have demonstrated that there's an increased risk of cardiovascular events following an RSV infection. And as I mentioned, the study included in total 131,379 citizens, and of these, 2,973 had heart failure at baseline. And for the primary endpoint of the RSV-related lower respiratory tract disease hospitalization, only 2 endpoints occurred in the heart failure group. Both of those were in the control group, but we could add limited conclusions on any effect modification for that endpoint outcome. However, the RSV vaccine was also associated with lower respiratory tract disease hospitalization for any respiratory disease, and also cardio-respiratory hospitalization for any cardio-respiratory disease. And the fact that the incidence was also lower in these categories with actually absolute greater numbers than the RSV specific outcomes suggests that maybe there were some RSV cases that were undiagnosed. And we found that the relative reductive effect was similar in individuals with and without heart failure. We also looked at the baseline risk, we also looked at the absolute benefit, where we found that the numbers needed to vaccinate to prevent a first event during one season was significantly lower in the individuals with heart failure.
It sounds like this is pretty supportive of making sure that we vaccinate older individuals with heart failure for RSV.
The findings, of course, suggest that there's some benefit to get from this. I mean, there's a whole discussion about the cost of this depending on the healthcare systems, but we definitely found that we can significantly reduce the rate of RSV hospitalizations by vaccinating against RSV, and that this vaccine effectiveness is consistent in individuals with heart failure as well as those without.
Yeah, no, one thing that I just find so astonishing, and I would love to hear more about your sort of trial platform, is this kind of, as you said, so you're looking at a specific population, individuals with heart failure.
Yeah.
But the only way you can really get at that subgroup is the fact that you have a massive trial, right? Which is that the overall trial, as you said, is over 130,000 individuals. In the United States, we don't really have anything a platform that can kind of do these tremendously large trials. I would just love to hear more about your trial platform and how you're able to do this.
The Danish healthcare system is a universal healthcare system for those that don't know. And in Denmark, when you're born, or if you immigrate to Denmark, you receive a unique personal identification number. And we have these registries in Denmark. We have that is used for administrative purposes. So every time you have an encounter with the healthcare system, either if it's a outpatient contact, you're hospitalized, or you pick up a prescription for some medication, then it's registered in these systems. And that allows us to conduct large-scale trials where we can extract our baseline data from these registries, and we can also follow up individuals in these registries. And that requires it makes data collection significantly easier, faster, and of course cheaper as well. So for this trial, there was only one trial visit for those individuals who were vaccinated, and the only thing collected during these visits were randomization status and their personal identification number.
And then, so I'd love your thoughts, since you're able to do these very large trials, I'd love your thoughts about how to think about, this question that you've, as a sub-analysis from the main paper, which is in the New England Journal of Medicine, the sub-analysis that we're doing in JACC is specifically around heart failure. So I would love your thoughts about evidence generation and small subgroups, heterogeneous treatment effects. Is it enough to simply say we checked the entire population and RSV vaccination works? How important is it to get at small subgroups? What reasons do you think that the effects of these vaccines might be different in smaller subgroups, such as individuals as those with heart failure?
That's a very good question, and there are, of course, limitations to doing this in this way. When you conduct trials of this size, we should look at as much knowledge that we can learn from, and therefore we think it's important to, of course, look at these subgroups, particularly those subgroups where either we may think that the vaccine may not be effective based on what we know from previous publications, or maybe see to not confirm, but see if the data suggests that if there's a particular subgroup at risk. I think it's important that we explore whether this vaccine may help in this subgroup as well, even though we, of course, have, when the main findings support it, it already suggests that, right? But we should do as much as possible to confirm whether or not it may work.
And then I guess my last question has to focus on, more how do we put this into action? These are important results. We're delighted to publish them today, and congratulations on your ESC presentation as well. I think that how do we lead into action here? Should we just make sure in clinic, seeing patients with heart failure, that we're thinking about 4-pillar guideline-directed medical therapy and additional vaccines, or are there other things that we could be doing, like registries or other ways to get vaccines to patients? Because a lot of patients that would potentially benefit from these therapies, prevention therapies, are probably not getting them. Is it just a matter of us trying to remember in clinic, or is there some other way to reimagine the healthcare delivery system to put these findings into action?
First of all, this study builds on a lot of previous observational studies, which during the last 10 to 20 years, we've realized that infectious diseases increase the risk of cardiovascular disease, and we now see that this may also vaccination may also help prevent complications from these infectious diseases in particularly individuals with cardiovascular disease. Whether this should be the, I don't think this should be the definitive answer of we should vaccinate everyone with heart failure, but it definitely makes us more aware of the importance of perhaps it makes us aware that vaccination may reduce the burden of disease for these individuals, at least. And as of right now, I know the HCC and HAHA guidelines support a recommendation for vaccination against any respiratory illnesses as a 2B to prevent mortality in heart failure patients. And I think these findings then helps nuance this recommendation.
Yeah, no, for sure. We are delighted to have it in JACC. Congrats again on your ESC presentation. And Dr. Skaarup, thank you for spending the time with me.
Thank you so much, Jason.